Whoa. So we're at the CFHA Psychiatry Special Interest Group, our monthly meeting, and it is the day after a holiday. So we're wondering about people not making it to the actual meeting, but I do know that there are folks who listen to the recording and look at any sort of resources on our CFHA Psych SIG website. And this opportunity to have this type of gathering, I really appreciate. I came up to Neftali at CFHA 3 or 4 years ago, and I said, "Where are all the psychiatrists?" And he said, "Well, start working. Let's bring more psychiatrists." So I know the organization has had fluctuations of membership, and it's a place that, as a psychiatrist and as a physician, I've really enjoyed connecting with team members of all types that we're all trying to do the same thing. And it really takes a team, it takes a family, it takes a village to do this type of work. And so I've really felt at home and welcomed within CFHA, and have been happy to try to bring this message out into the different communities and associations that I'm in. So I really appreciate you, Neftali, as a person and your teaching and leadership for CFHA, and then to do this presentation today is really helpful. And although most people know you, it might help if you start talking. I know you're the CEO of CFHA. If you would tell a little bit about yourself, and although we're a small group today, we know that the recording definitely is going to be useful. So I appreciate your time.
Sure. Yeah, absolutely. Thanks, Patty. Yeah, I'm Neftali Serrano. I'm the CEO here at the Collaborative Family Healthcare Association. We are a nonprofit member association dedicated to supporting healthcare professionals and integrating physical and behavioral healthcare. See how that rolls off my tongue because I've said it so many times. Yeah, so we're passionate about team-based care. That's really what it comes down to. In fact, what really makes CFHA unique, and certainly what's colored my career, is really an emphasis on team, a de-emphasis on guilds, not because guilds are not important or useful, but simply because they have limitations, particularly in the delivery of healthcare. So when we gather together around a patient and their family, we really have a vision for putting aside our guild interests and really centering in on patient interests and the team's interest as well. We're passionate, just as passionate about the health of the team as we are about the health of the patient. And that focus makes healthcare, first of all, a lot more fun, but we feel like also a lot more effective. And so today, you're going to hear some of my background come out in this talk. I'm going to be talking about why integrated care models are difficult to implement, why Fidelity is difficult, and what you're going to hear, what I'm hoping you understand about my background and why I feel like I have something to say in this area is because I've spent really all 21 plus years of my professional career implementing integrated care models at various clinics, my own, but then also in consulting relationships, even very early on in the early 2000s, because I was sort of an early adopter, fallen into this kind of work. Other clinics started asking for help, technical assistance. I barely even knew what I was doing back then, but I got into the technical assistance game pretty early, just out of a desire and a passion to spread sort of the good word of how great this new thing that I had found in my career was. And so you're going to hear the implementer. You're going to hear someone who struggled with adapting research to practice. Early on, there was very little, if any, guiding research related to the model of care that I was trying to implement, the PCBH model. And so a lot of what I was asking myself early on was, well, how do you adapt evidence-based CBT to a primary care setting? And then as my patients had more and more complex psychiatric needs, together with my physicians, I was asking, well, how do we adapt evidence-based psychiatric prescribing to a primary care setting, right? And same sorts of questions as COCM emerged as a model. Well, how do we take what is a robust literature and adapt it to places that are demonstrating significant resistance for one reason or another, right? So that's been basically my entire career, is just trying to figure out how do we make this work in all of these different kinds of settings, even though we might all be talking about implementing integrated care in a primary care setting. Not every primary care setting is the exact same sort of animal. So you're going to hear that part of my background. The other part of my background that informs what I'm talking about here is that most of my background has been at FQHCs, or federally qualified health centers. So underserved populations, patients with complex, multiple psychosocial needs, et cetera. So the idea of a simple patient is something that I have not seen in my career, literally. Right now, I do have a small practice at the University of North Carolina Department of Family Medicine here in Chapel Hill, North Carolina. And it's still, in my practice, still operates very much like an academic safety net type program. So you're going to hear that bias and that perspective of the complex patient, the patient with multiple comorbidities and psychosocial issues and high ACE scores and potentially substance abuse, et cetera. So that all of that informs how I think about adapting an idea or a model, looking at research, and then trying to bring it down to the ground of making it work in a particular clinic setting. Okay, so this is what we're going to do. We're going to try to focus in, and I intentionally don't have slides for this kind of a thing because I think slides oversimplify things. And actually, one of the things I'm going to try to help you understand is that it actually makes a lot of sense why models are difficult to implement with Fidelity. It makes more sense than less sense, that the status quo is the status quo. And I will say that one of the things that I'm going to talk about here today that I'm not an expert in, and I'm not trying to portray myself as an expert in, but that has helped me encapsulate my thinking as I've provided technical assistance to lots of settings. I've had these sort of instincts that have emerged that I've learned to adapt when I go into a clinic and I realize that there's resistance and there's these political complexities and I'm trying to get people to make changes here or there. I have these instincts that have come up, and this approach that I'm going to talk about has put words to that instinct. And the approach is an area of study called complexity science. And if you've never heard of complexity science, I really encourage you just do a basic search on it. Lots of stuff will come up. There are societies now that gather around this whole idea of complexity science. But the basic idea that complexity science has helped me to encapsulate is the idea that when we talk about models, we talk about it in a very, what they would say, a very Newtonian approach. So we think about organizations and healthcare delivery in particular like a machine. And so a machine with its parts and its inputs and its outputs. It's more sort of one way to think about it is more of an assembly line style approach to healthcare delivery, essentially. And in our models, the way we treat our models in a way, typically have that as an underpinning, that understanding that healthcare is sort of a machine. And all we have to do is fix the machine. If we fix the machine, it would give us the result that we want out of it. And that's an interesting sort of assumption. First of all, if you just think about the complexity of healthcare, right? You ask 12 people what healthcare is supposed to deliver, you're going to get 12 different answers, right? It's a complex thing. And so most people then focus in on, well, it's just a complex machine. We just have to kind of think better about the machine, or think more sophisticatedly about the machine. And if we fix each of the component parts, we should be able to get the results that we want out of it. So that's a Newtonian approach to models and to science. So complexity science says, wait a second. If we really learn from science, particularly biological science or even modern day physics, we really should understand that the living system is actually a better metaphor for healthcare and healthcare delivery. So if you think about an ecosystem and the complexity of the relationships between organisms in an ecosystem, between settings in an ecosystem. So if you think about a sort of a swampy area, and you've got, all the creatures that live in the water, and you've got the creatures that are hybrid creatures that live in the water and on land. You've got creatures that live in the dirt. You've got creatures that live in the trees, etc. And what modern biology and learnings on ecosystems tell us is that this is not a machine. This is a highly interdependent, multi-relational, multi-nodal system. And so messing with one piece of the system naturally has downstream effects with other parts of that system. And so that then, from a complexity science approach, is the best way of thinking about healthcare delivery and healthcare delivery systems. So if you take that approach, it really then helps you understand that if you're going to artificially drop in a model, no matter how great that model is, into a system, you're going to understand that something's going to be disturbed, right? Some balance, some harmony is going to be disturbed, even though, and this is where we often get tripped up, because we come in with a lot of enthusiasm. We say, well, we're here to fix something in the system, right? Doesn't the system want this fix? Isn't it obvious that this fix is going to help you, right? Again, that's a very mechanistic understanding of the system. I'm going to talk here in a minute about really analyzing and being able to view these living systems from a different lens, so that you understand better why it is when you do attempt to drop a model like this into an ecosystem, how a well-intentioned effort can often result in significant resistance and sometimes outright rejection of that intervention, that model that you're trying to propose. Now, I'm going to also drop in some links to all of this, so that those of you who want to read some more, there's actually a great PDF of a conference that was held on complexity science and healthcare that I would encourage you. It's just a few pages to read, but it's a great intro into this sort of thinking about it. And I'm also going to give you a link to the notes that I have prepared for today, which will flesh out all of this for you as well. But the fundamental that I want you to kind of have is that image in your mind of the difference between a machine and a living system. And I love this quote that's in that PDF that I'm going to drop here in a second into the chat. It says, variety and change characterize complexity, as opposed to simple, linear, and additive relationships, which are characteristic of Newtonian thinking, right? And that encapsulates the problem that we face when we drop in a model into a system and just assume that it just becomes another cog, another gear that we add to the machine that's supposed to produce a better output. We're not understanding that we are introducing change into the system that is dynamic. It's going to dynamically restabilize the system. Now, a couple of things that are helpful to, I think about when you think about this metaphor is to think about ecosystems that are made up of different organisms, and that have these networks, or what are called complex adaptive groups. So when I think about going into a clinic, I'm always thinking about the particular individuals that make up sort of subsystems in the ecosystem. So I may think about, I often think about medical assistants, because medical assistants are so crucial to the operation of a typical primary care clinic. They can make the atmosphere and tenor of a clinic a cheerful, bright, problem-solving oriented place, or they can make a clinic feel dark, negative, and chronically whiny and negative, right? And so these are a part of the ecosystem. These individuals are an important part of the ecosystem that I'm always trying to pay attention and say, what role do they play in this ecosystem, right? And I often ask questions about power. Do we have empowered medical assistants, or do we have disempowered medical assistants? Because guess what? If you ask a disempowered medical assistant to administer PHQ-9s on whatever interval you're trying to achieve, whether it's every annual well visit or whether it's patients with depression in the diagnosis, whatever it is, when you do that, well, what do you usually get? You get a whole lot of resistance. You get very, very poor compliance. You get all sorts of different excuses for why this and this is not possible or not working well, right? It's because you've entered into an ecosystem where that group is in a threatened state. And any sort of additional ask of that group is going to elicit a response. I think the same thing about groups like coders and billers. They may not be the first people you think about when you're implementing a model for integrated care, but you will get tremendous resistance from coders and billers who are under pressure, under stress, for other areas of billing and performance, revenue cycle issues, et cetera. If you, I think about the upper level senior leadership, right? And I try to assess what's the state of that part of the ecosystem. And if you have a particularly toxic relationship between the CFO and the CEO, now you may not think, well, why would that matter with regard to how you're implementing a model down on the clinic floor? But it absolutely does, because their relationships with parts of the clinical teams and how they are either support or don't support various efforts can sink or swim your efforts at the patient level, right? So that's what thinking about complex adaptive systems makes you think about. You have to think about each of the organisms and the nodes of these complex adaptive groups, which each interact with one another. So you can think of it as almost like drawing up a very complex array of nodes with lines and relationships with one another that form up the organism. And every organization you go to, those of you who have worked at more than one organization know this, every organization you go to has a very distinct array of nodes and how they interrelate with one another and how effective they are at producing ends that the team is trying to achieve. So understanding that ecosystem approach to me is fundamental to understanding how to effectively implement models of any kind in a clinic setting. So that is really the fundamental answer as to why it's so hard to implement models of integrated care with any fidelity. That's simply the way life is. Now, I want to get to then what are some of the sort of pragmatics, right, of how you deal with these systems. So one of the things obviously is having some way to assess, right, what the state of the organism is, what the state of all the subsystems in that organism are, all the power players, all the groups, all the nodes. And what you want to do is you want to start doing what folks in complexity science do a lot of, is ask dangerous questions. And this is the part I love about complexity science, because it really does encourage you to ask sort of fundamental questions about the isness and the whyness of things, because you have to understand, what is this organism trying to achieve? Now, again, you might say it's primary care. Don't you know what the organism is trying to achieve? It's trying to achieve primary care stuff, right? And that's too simplistic a level of understanding. So what you really want to ask is, what is this system really trying to achieve at its core? And what you'll often find is that there's multiple things that a system is trying to achieve, some of which are absolutely contradictory to one another. And thus you will find instances where in the ecosystem there is tension, right? There's actually predator and prey, to extend the metaphor, within the ecosystem. There's competition for what the system is actually trying to achieve, right? So a good gross set of goals or ends is typically an end called revenue, right? And although no healthcare entity out there puts a billboard and says, we exist to create revenue, the reality is that that is a major goal of almost every healthcare entity in the United States, to create revenue, right? So if you think about that in the context of the organism, you're going to have parts of that organism or nodes in that organism that are hyper-focused on revenue production, revenue creation, right? And then another typical potential end is status, organizational status. I find this a lot mostly with academic settings, where the end is really getting the big research grants, or having a certain status in the community. And that is a very, very different end, right, than good patient care, right? However we might define good patient care, right? So it's important to simply begin to tease out, when you look at an entity, what are the ends or end goals of that organization? The other thing that complexity science does very well is it looks at the ends themselves. It looks and says, well, what is the organization producing, right? Because the assumption is that if the organization is producing X, and especially if it's producing it efficiently, then that's really what the organization is designed to do. That's what the system is designed to do. So the dangerous question that you often then ask is, well, is that what we're supposed to be doing? Because that's what we are doing, right? So if an organization, for example, it's sort of like saying, well, if we have poor maternal child health outcomes, you would then have to ask yourself the dangerous question of, is that what our system is designed to do? And that's a dangerous question, because the answer very well might be yes. Yes, our system is not culturally adaptive. Yes, our system does not have a culture of data. Yes, our system does not engage community members well. And as a result, absolutely, our system is designed to produce poor maternal child health outcomes. Do you see what I'm saying? right? So you want to look at the actual ends and don't say, oh, this is an aberration. No, you say that, well, okay, so what about our system is actually producing this particular outcome, right? And that's a hard question for organizations to ask. Usually organizations like us as individuals, save face and feel like, no, we're just working really hard and it's just a hard thing to do. It's not always that there's bad intention, but systems, as we have learned in the last year, certainly when we think about issues of race and equity, systems produce the ends that they're intended to produce. And asking those dangerous questions is challenging, it's difficult, but it's absolutely essential if you're going to inject a model external to the system into a system cold. So you want to ask those dangerous questions of the organization, but you also want to ask those questions of the agents in the organization. What are they trying to achieve? Because that's the other piece that we often don't pay attention to, right? So some of the agents in the organization might be really focused on attaining tenure, right? That's a particular goal that requires a particular kind of energy. Some within the organization might be focused on training future physicians, right? This would be an academic setting. There have been many times when I've gone into an academic setting to integrate a model of care, and there's been resistance because there's some within the residency program who feel like the focus should be on training future physicians to do integrated care work, not on bringing in, psychiatry or external behavioral health to provide, these integrated care models that we know work. No, we've got to train our physicians so they know how to do it, right? And not to get too crass, but some agents in the organization might just be looking for a paycheck, right? They're there for money to get what they want to have happen. Now, when you take a complex approach, you're never judging any of this. This is also goes very well with a very Zen Buddhist mentality. You're not going in and saying, oh, your system sucks. You don't have good goals, or you guys just need to get your priorities straight. No. The idea is really to understand the interplay of each of these powers in the organization, these nodes, and to understand it enough so that when you begin to try to inject an integrated care model, you are doing so with an awareness of where to position it and how to position it with each of the players in that particular organization in an effective way. And as I'll talk about here in a moment, potentially scale back some of your expectations and some of your initial efforts so that you don't produce a sort of, this is another metaphor I use a lot here, where you have organ rejection, right? The body is a great example of a great ecosystem, right? Of this whole approach. What happens when you try to inject an organ, right? Oftentimes you get rejection of that, even though your body needs that liver, right? But there is something innate about the organism that is trying to maintain homeostasis, protect itself from infection and disease, and rejects the organ. So in the same way, we need to be very, very cognizant when we inject a model of integrated care to do it in a manner that is paced with what's happening within the organization. I'll talk a little bit more detail there in a second. But so there's this idea. You want to ask what the ends of the organization are. You want to have an understanding of what the agents in the organization are also trying to achieve. And lastly, although it shouldn't necessarily be last, but it is last usually in the order of things, you do want to ask what the patients are trying to achieve. They're part of the ecosystem too, right? Isn't it funny that they're the last ones that we address, but they are, just because that's in the order of implementation. Typically, that's where you typically work your way, because to get to the patients, you have to get through the system first, typically. But patients have very different agendas in different communities. And they sometimes do not fit our models terribly well. Let me give you a couple of stories here to highlight this reality. So let's call this one patient. These are both real patients with, no identifying information. But let's call this one patient Walter. Walter is an individual who many of you probably have seen in your practices, a patient with lifelong depression. Sort of like the idea that if you around this patient has never been happy, right? That's the impression that the patient will give you on most any visit. Likely some borderline-ish personality traits at the very least. Definitely chronically suicidal, a very lonely individual. Also happens to live in a very adverse environment, lives with family that's not terribly supportive and also pretty toxic. And this patient has gone through literally every medication trial possible, has been through tons of psychotherapy in his life. Walter is a great example for me of someone who doesn't fit any of the models, literally any of the models, right? I mean, if I try to see him in PCBH, which this is someone who I do see, right? Walter is stretching the boundaries of that model, right? There's not enough time in the world for me to spend with Walter that would get to the ends of what he's trying to achieve, nor what the model tells me I should be trying to achieve. Walter is also not a good fit for COCM. There's not enough care manager contact or psychiatry follow-up that's going to kind of restabilize or rejigger things for Walter. He's not a great fit for specialty therapy either, ironically enough. And literally, I know that because he's been through lots of rounds of specialty therapy. And I suppose we could say, well, it wasn't good enough specialty therapy, but I don't suspect that that's the case. He's just like medication. I think there's a lot of therapy non-responders, right? I think that's just the reality of things, right? Specialty psychiatry, same thing. Again, he's been through lots of medication trials, right? So Walter doesn't fit any of the models terribly well. What Walter wants is something different. And I've had to challenge myself from within my role within the primary care team to figure out how can I adapt what I do to approximate some of what he needs. So my goal with Walter right now is not a terribly PCBH-ish, COCM-ish role. It's really a negotiation in a way. Like, I think Walter is lonely and he likes to have someone to have some contact. My goal is to keep him as stable and non-threatening to himself and his life as absolutely possible. I hope to keep him out of the emergency department and out of the hospital as much as absolutely possible. Through that, I hope to teach him some resiliency skills. I'm helping to facilitate a trial on ketamine, and we're going to go from there, right? But Walter's someone who, especially as an elderly person, who is not fitting any of these sorts of models perfectly, right? So that encapsulates for me why models are important but not sufficient. None of these models solve all of the needs of the ecosystem, right? And that, in fact, is one of the concerns that people will often raise. Clinicians will often raise, clinicians who are well tied to their communities. They will often point out the instances in the population that do not fit the models that you're trying to propose to them, right? So if you're working on a COCM implementation, this is like the standard thing I'm going to hear. It's going to be like, well, but that's not going to work for my kid with ADHD, my homeless guy with bipolar and my borderline personality patient that comes in every week and, makes a mess of the waiting room, right? You're going to hear those sorts of stories. Now, that's not to say, again, I'm not here talking down about models. I actually care about models. I think they're important, especially for training professionals to work effectively in a team. But it's simply another way to, another example of this complexity approach, that you must look at the entire ecosystem and the complexity inherent in the ecosystem to learn how your model is going to be received. You can come in with all the research in the world and all the good intentions in the world, and unfortunately, you're just going to elicit, if you're not attuned to the ecosystem, you're going to elicit a tons of resistance and potentially a failed implementation. So let me give you some examples of how I have seen places resist implementation, particularly when I have not done it effectively, when I have not taken a good enough complexity approach. So I'll start with PCBH. PCBH, of course, looks to solve the access to a mental health specialist issue. That's what that model is trying to do. Ironically enough, the parts of an ecosystem that typically reject PCBH the most are the mental health personnel. So if a place has existing specialty therapists, for example, and they're trying to be repositioned by the organization from their specialty role into the primary care setting, there is tremendous resistance to the idea of collaborating with primary care providers in a very close way, of doing 15 to 30-minute visits, of adapting to a no intake procedure. There's tremendous resistance that typically happens there. Sometimes there's resistance from providers who don't like handing, they really just want to turf patients. They don't really want to collaborate on patient care. And so the idea that they will be working with a consultant as opposed to just filling out a referral and handing it off to someone who then, takes care of the situation is a very typical sort of response for PCBH as a model. And as a result, with PCBH, when I see that a system is not really ideally arrayed for a traditional PCBH implementation, I have to work with a mutation. And that's a good way of thinking about it, right? In an ecosystem, you adapt or you die, right? So I could try to implement a perfect fidelity PCBH model, but if the organisms in that ecosystem are not going to sustain that or not going to adapt to that level of fidelity, what's going to happen? It's going to be rejected and it's going to die. It will not exist 6 months after I'm gone as a consultant trying to make this work. So mutations include things like behavioral health personnel operating more as specialists. So they retain some of their hour-long sessions. They may have some warm handoffs that they facilitate, but those warm handoffs are not the robust warm handoffs that PCBH does. PCBH is all about making use of every moment with the patient. A lot of times in these mutations, it's just really a meet and greet and let me schedule you for a visit kind of a thing. So other mutations include maybe a couple of engaged providers that are really working collaboratively with the behavioral health personnel, and a large group of the medical providers not really engaged on any level, right? So those are adaptations that often can be sort of stage 1 program development stages that are helpful. With COCM, you'll have many similar types of resistance. Some that I'll highlight, I talked about some of these before, where you have a lot of resistance from the personnel involved in screening. So I can't tell you, it's really interesting how difficult something like just implementing a paper and pencil screen can be in a clinic setting. Something that you'd think, boy, we're just handing someone a piece of paper to fill out. Shouldn't that be something that we could do pretty easily or seamlessly? But again, if you don't have medical assistants well-trained, on board, understanding from a cultural standpoint, why is it we're doing this? Why is it important? What role they have in the larger scheme of identifying patients in need, you often will get lots and lots of resistance there. You also get resistance from billers because they don't understand CM billing, and they'll give up without even trying. And just even getting them to experiment and to rejigger their systems, whether it's the documentation systems or the back-end billing systems, can be challenging, right? And then, as I talked about before, if you have mental health personnel on board or primary care providers, they'll often complain about the scope. It's too narrow. We really have a lot of patients that fall outside of this scope, and then they're not willing to say, hey, let's do a good job with these patients within the scope, and then maybe we can broaden the scope after the fact to those. So again, you have mutations of COCM. I've seen them all over the place, right? You have mutations where you have a registry, but you really do have high dropout rates for uncontactable patients in that registry, right? And that's a key issue in some certain communities where telephone contact is difficult, and reaching out to patients and getting them back into clinic can be difficult. Or mutations where you just have much more fluid contact schedules, right? So if you know COCM, you know you really have a cadence of contact that you want to have with your patients. And that coincides typically with re-administering the PHQ-9 as you go. You see a lot of implementations that don't follow that cadence terribly well, right? It may be more spaced out. So maybe patients are getting contacted once every 4 to 6 weeks, as opposed to every couple of weeks in the beginning of treatment, of the treatment phase. So all of these pieces, you could say, well, that's not COCM or that's not PCBH. For me, as an implementer, I don't see it that way. I say, well, that is where this organism is right now in its capacity to integrate care. And I try to understand what are the dynamics in that system that are keeping that implementation at that level. And my goal often is to optimize that version of the implementation as much as possible, identify the restraints in the ecosystem. They could be people, it could be systems, and as part of a phase 2 attempt, work with those restraints and remove those, modify those to work towards something that looks a little bit more like the fidelity that I might want to see in that. Now, with all of that said, the key thing that complexity science looks at, because it's looking at this as an organism, from an organism and ecosystem perspective, is really the key thing that I look at when I think and when I try to project how effective a particular implementation is going to be. I wonder if you can guess what the single most important variable I think needs to exist for a successful implementation. Just take a moment to try to think through. If you have an ecosystem approach, you're thinking through this living organism, and you think, what cuts across all of these nodes, right? What factor is essential to the functioning of this ecosystem. And I see the things in the chat. Yeah, communication, training, education, the inputs, etc. Well, it's not going to be terribly surprising to you all when I say what it is. I think you all are beating around the bush a little bit, but it's leadership and culture. So if you have strong leadership, you have the ability to bring the tensions and the contradictions in a system, even while they exist, because they exist in every organization. You have the ability to bring those into a closer working relationship with one another. And the PDF that I referenced has some really interesting descriptions of what leadership looks like from a complexity approach. Stuff that's not going to necessarily rock your world, but it also looks at some of the competencies that leaders who manage ecosystems effectively have. And these are things you can look for when you're thinking about whether a system is going to be well suited to achieve high model fidelity or low model fidelity, right? So you can reference that PDF, but I'll name a few of them here. So one of them is the art of managing context. Good leaders understand context and are able to manage the context that the medical assistants live in, that the billing department lives in, that registration lives in, that clinicians live in, right? They have an understanding of the complex interplay of these different places and are able to manage context effectively. Not surprisingly, they learn how to flow with change. So they're not rigid leaders who have a sort of set idea and then are not going to deviate from that. They're willing to move from their particular position. Something that I love that complexity science does well that also is a leadership competency is working with contradiction. And that's really important. Our organizations are littered, our healthcare organizations are littered with contradictions all over the place, starting from that basic point we made before, that we are a revenue-driven entity that's supposed to be there to take care of patients, right? That's a contradiction oftentimes, that those two don't often align terribly well, right? But learning how to work with that contradiction is what good leaders do. Emergence and self-organization is also an important leadership trait. So this is where, again, you don't have an organization that has strong top-down leadership, but actually allows for self-organization, right? So it recognizes that change is inevitable. So if you establish a rigid organizational structure, you're just going to set yourself up for needing to adapt to the next change and being destabilized, as opposed to really allowing teams and parts of an organization to emerge and grow in a much more naturalistic fashion and change and adapt, certainly with strong leadership to hem it into a coherent whole, but having that understanding that change is the constant in any organization. So I look for these qualities in an organization. Not surprisingly, when I find an organization does not have strong leadership, does not have this sort of inherent flexibility in its approach, my efforts to integrate a model usually fall flat. So I use that as a way to gauge early on whether I'm going to shoot for high fidelity or whether I'm going to shoot for a mutated version that I think has some chance of surviving in this hostile organism. And sometimes that's all we can do. Now, I'll end here. I don't want to downplay these mutations as if they are not significant, right? Because the mutations are there and they're part of, it's just part of life. Mutations are a part of life. We all literally live with biological mutations within us. We certainly live with them in our organizations. I've seen some great mutations out there, right? In psychiatry, there's lots of folks that have a generalist consulting psychiatry approach that works really well, where they've got it, they don't have the registry and they don't have the great tracking that's at the heart and soul of COCM, but they've been successfully able to integrate a consulting psychiatrist to support their primary care providers, right? That would be a phase one. And given that I can work with the ecosystem effectively, we could take that to stage two and potentially add in the tracking and the registry after that initial phase. That could be one way to potentially work to bring the benefits of COCM into that particular system. So you don't have to downplay mutations as if they're always something bad. They can be, particularly if they're very poorly adapted mutations. So some mutations are, cancerous, obviously. Same thing in a organizational setting, right? It can be a mutation that doesn't really achieve any of the goals of integrated care. It's just like, I would describe that as like when we're trying to plop specialty therapy into a primary care setting. Like that kind of mutation doesn't survive typically very well, and it does poorly, right? So I've had psychiatrists and behavioral health colleagues who try to do that. They try to do specialty psychiatry or specialty therapy in a primary care setting, and inevitably it just doesn't work out terribly well, right? So there can be poor mutations, but not all mutations are bad. And we can actually use many of them to build on sort of a suitability and acceptability over time. But leadership and culture are going to always be a big part of that, which is why if you read any of the stuff that Jürgen has put out on implementation, or any of the stuff that any of the folks on the PCBH side have put out, you're going to see the same thing. You're going to see if the organization does not have a culture that understands the end goals of integrated care, you're not going to be able to achieve model fidelity, because we can't just drop these models into these living organisms and expect the same results that we see in a research trial that is highly, highly controlled, right? So to me, to bring it back to the beginning, I am not surprised when models that I see in a clinic are not matching what happens in a research trial. That to me would be the exception rather than the rule. Now, we can work towards some sense of fidelity, and I think we'll end with this commentary. I think what we really want to be clear when we think about models is we really want to be clear on what the end goals of those models are. So I often think about, what is the key end of the model? What is it trying to achieve? And then I ask, what are the key ingredients? And how can we approximate the key ingredients of that model? There's this great paper, I think it was, oh boy, I think it was Jürgen, but it may have been one of the other folks out of the AIM Center, who wrote about the sort of the key components of COCM. And essentially the key components were the tracking and the communication systems, right? So the idea that you're tracking patients in a registry and you have these robust communication systems between primary care and your care manager and your psychiatrist, that's what you want to see, right? Now, there's lots of mutations where you can have those components in. They may not look exactly like the COCM research trial, but that's okay, potentially as an initial attempt or as an initial implementation, essentially. So I think if we take our eyes off of the idea of fidelity and we say, what is this model trying to achieve? What are the key ingredients and how can it be adapted within this particular organism? We tend to have a more successful first implementation of that particular model. All right, so I've talked a lot, I'm sorry, gone on and on here, but you'll see that my approach is very pragmatic in nature. I'm really trying to say, how do we help organizations, pun intended perhaps, how do we help organizations effectively do integrated care? And I haven't yet, I've probably worked on over 100 different projects in my career. I haven't yet found one that looked exactly like another. I just haven't been able to make that happen.
This has been great, Neftali. I appreciate the comparison to an ecosystem, and it really fits. And so I was just curious if anybody else had any other comments. We've got some expert implementers on this call, and Neftali has put the PDF in the chat, and I'll also put it into our email and on the website.
Yeah, so there's a PDF and then there's a link to the notes for the talk today that you can just kind of peruse if you like.
I appreciated your talk as well, Neftali. My sister does the same system dynamics thing, so she lectures me about it, which is always interesting, and I always learn things about it. I sort of sometimes think that Fidelity is for sort of broader outcomes, system outcomes, like a research study does. But we see a lot of individuals. And so the challenge is then in the setting we're in and with the individuals we're taking care of, if we stay focused on the system outcomes, a lot of people don't fit, and we have to then discard them or not treat them or refer them. And that's hard to do. And as we try to adjust to the individuals we see, we drift away from those system outcomes. At Mayo, I've just been amazed at how long we've been doing CLCM, and we still don't measure remission rates by site, which would be the system outcome that we should have been measuring all along. But it's just so hard to do that. It's much easier to look at things that relate to throughput and how many patients you took care of, and are you doing the work? So I agree with you. I was struck by how Walter approach Walter with what does Walter need rather than what my model does. You have to do the same with a clinic. What does the clinic, where's the clinic? What does it need? I have models, but they're imperfect. So start with where they are. Thanks for the talk.
Yeah, appreciate it. Yeah, agree 100%. And I think you may hear me talk to a different audience very differently than you guys. There's some audiences where I am talking very much about models and fidelity. That's usually when I'm talking to my fellow psychologists or social workers who need to hear boundaries because they don't like the boundaries very well. And that's where models are helpful, right? Because models help me as a trainer train a psychologist to know how to interact in a primary care environment, right? They can help me train that person in a model with boundaries for professional development. But models are not, as you said, Mark, perfect at caring for every patient. And those two are different ends. I need the model to train my staff. I need to be able to think outside of the models to care for every patient that I encounter.
One of the challenges I've encountered with these integrated care models is that in some ways you're pushing on it's like you transplanted an organ, but that organ is, always trying to interact with all the other parts of the system. And a lot of them are having to adapt to it. So, there's sort of all of those relationships happening throughout the whole system. We opened a med psych unit and had, a very similar experience to trying to, integrate care in the outpatient setting. Everyone thought that the med psych unit would be the solution to all of the problems of the system, but there are so many problems that it doesn't solve. And it's the same with collaborative care or with other outpatient integrated care programs. You just can't be the whole answer. But I do think it has been helpful to realize that, and then to be able to help the person, wishing that you were solving their problem, understand what their problem is better, and so that they can start to look for other solutions. So
that's exactly right. That's such a great insight. That's such a great insight. That's exactly right. That's sort of, it's clarified for me on a larger system level, right? In primary care, public health experts tell us that we account for, as a health system, about 15% of the overall outcomes in
Right.
health, right?
Right.
And that's important because when I think about integrated care, people often say, well, the answer to good primary care is integrated care. I'm like, no, the answer to good health is not even primary care. Right. So
Yeah.
let's have reasonable expectations and understand. And that then does help because then you identify, as you said, what the issues actually are. And you
Mhm.
start realizing, well, we've got to start working on social determinants of health here, right? That may take us a little bit outside of our exam rooms
Mhm.
as far as intervention points and solutions, right?
Mhm.
But that's helpful. That we want to do a good job with our sphere, and I certainly want primary care teams to be arrayed and able to meet the needs of patients who walk through the doors of the clinic, and recognize that there are things that we cannot solve, no matter how well organized we are as a team, no matter how well we work together.
Mhm.
They're not in the scope of at least the way we traditionally define primary care. That's helpful.
Agree.
It's very helpful because so many lectures and teaching about implementation make it sound so easy. And that's just like you just do this, 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 and that, and it's going to work. So it's easy to take it on myself to think that, well, I'm just not doing it right. Or so this is really, really helpful. Well, I know that some folks had to check out, and I'm happy to stay on. And Neftali, you may be able to, but we appreciate your time and good to see you